A very good afternoon, everybody. So I think after that exhaustive lecture by Professor Rabih, we will now go through cases which will help us in prognosticating fetal CNS abnormalities. My job here is very easy today because I am only going to learn how to run this flight. And why CNS problems today is because we all know that CNS problems are the second commonest birth defects after cardiac abnormalities, with the incidence being around 1 to 10 per thousand live births. Now, the problem with CNS abnormalities most of the times is that at times the prenatal diagnosis can go wrong. There may be associated abnormalities which may manifest later, or you can have anomalies which may progress and impact the outcome. Now, today I have a team of superheroes with me who really do not need any introduction. I have Suresh sir, Ramamurthy sir, Praveen sir, Mohit Shah sir, Dr. Seneesh, and Dr. Shagun in the panel. And none of them need any introduction. So without wasting much time, I would move on to the first case. Now, this is a 23-year-old primie. Her first trimester screen was negative, and she came to us for a second opinion for mild ventriculomegaly at 26 weeks. Now, if you look at the scan images, video and audio. Am I audible?
Yeah, you are.
Yeah. Yes. So if you look at the ventricle measurements on both the sides, you see that the ventricles are measuring as 11 millimeters and 12 millimeters, which was suggestive of mild ventriculomegaly. Now, but before we go further to the case, I think the most common dilemma that we all have is how do we measure the ventricles? Because all of us have learned that you're supposed to measure it at the level of the glomus, which for a lot of us is here. For some of us, we measure it at this point, and for a lot of others, probably at this point. So what we need is clarity here. And Mohit sir, can you please describe for all of us what are the landmarks that we need to see when we are trying to measure the ventricles so that we can give them a correct assessment?
Well, first of all, we need to get the head in a correct axial section. And you will know it it's a perfect axial section when you see there's a symmetry between the hemispheres. So we would like to measure the ventricle which is far away from the transducer, because obviously the near one gets obliterated by the bone shadow. Once you've done that, I would like to zoom the image. I like to zoom the image to one hemisphere of it so that it really stands out. And then you identify the parieto-occipital fissure. Now, this is a 26-weeker, so you're seeing it very obviously, but in a 20-weeker, you will just see a mild indentation of the medial cerebral hemisphere. And then you see and adjust your contrast settings so that you can see the ventricular walls very clearly. And you measure the ventricles at the level of the atrium. The atrium is at the deepest point of the parieto-occipital fissure. So you place your calipers on the medial and on the lateral wall of the atrium, perpendicular to the long axis of the ventricle. Yeah, that's the correct way. On the medial and on the lateral wall of the atrium is a correct way to go. And that is one of the reasons why you need a good zoomed image. If you do not zoom it properly, your caliper placement may not be accurate. And if you're dealing with a cutoff of 10 millimeters, that's a very narrow margin to play with. I think that should be good, Meenu.
Yeah, thank you, sir. So Seneesh, Mohit sir has been actually stressing on the fact that, identifying the parieto-occipital fissure is really, really important because that is one of the major landmarks. So can you once again reiterate as to how do you identify this parieto-occipital fissure on ultrasound?
Okay, thank you, Meenu, for the question. Now, in the otherwise complicated fetal brain, there are some structures or some landmarks that actually stand out or that are very conspicuous. And thankfully, one of them is the parieto-occipital fissure, also sometimes called as a parieto-occipital sulcus. Now, this is best assessed in the transventricular plane one of the standard planes that ICOG recommends. Now, the actual appearance of this fissure depends on the gestational age, as Mohit Shah sir had said. Now, most of us do anomaly scan around 19 to 20 weeks. And in 3/4 of the cases, this parieto-occipital fissure would already have been started appearing. Usually, it appears as a small indentation on the medial aspect of the cerebral hemisphere towards the anterior aspect of the fetal brain. Now, slowly, it shapes itself into a broad V, and followed by a narrow V, and then towards a later gestation, it becomes an I. So take the transventricular plane, zoom it, go to the anterior aspect, and you see a V, or a narrow V, or a broad V, or sometimes a small indentation. If you are around 19 to 20 weeks anteriorly, that's your parieto-occipital fissure.
Yeah. So we all know that anything that is less than 10 millimeters is considered as normal. Between 10 to 15, we use the terminology as mild ventriculomegaly, which is what we used in our case. And anything that is more than 15 millimeters is termed as severe ventriculomegaly. Now, so we understood till now that all these landmarks that we are using are basically to actually view your the far ventricle. But Ramamurthy sir, can you please tell us how do we assess the near ventricle? Because that's always a dilemma. How do you look at it? Because it always gets obliterated because of artifacts.
Well, good afternoon. Thanks to Dr. Ashok Khurana and Dr. TLN Praveen. Another lovely Sunday on hand. And many best returns to you, Dr. Meenu.
Thank you, sir.
Now, the near ventricle is a must to be studied. We're not doing the fetus a favor. It should be in our protocol. So once you get your far ventricle and you do your measurement, reflexly, you must go on to the near ventricle. And how do I do that? I do a translatory movement along the axial, keeping the axial section in view. I go across to the posterior aspect and then angulate it. And when I angulate, the midline actually tilts to about 30 degrees. And in that position, with a little gentle rocking, you will suddenly get to see the near ventricle, as you can see in this clip as it's playing. You can see it there beautifully. And that is how you see the lateral wall, the medial wall, and the plug of the choroid in between. You will not see a glorious big stretch. Even that small bit is enough to tell you that it's normal sized or large sized. Now, it's very important that we're trying to do two things. First is just to have a visual impression of saying, yes, is it dilated or you can make do with the non-axial section. But if you want to document the ventricle in terms of a measurement, you've got to follow rules again. It has to be an axial section. So freeze when you have symmetry of both the hemispheres and you're able to see the medial and lateral walls of the near ventricle. You can take your inner to inner measurement at the parieto-occipital fissure, as was described by Seneesh and Mohit before. Now, if you don't see or make it a protocol to see the near ventricle in your scans, you will miss 1/2 of unilateral lateral ventriculomegalies. That is the implication. If you say, I don't mind missing unilateral lateral ventriculomegaly, then you can give up. But remember, unilateral lateral ventriculomegaly is as important as bilateral lateral ventriculomegaly, and you will do this only if you see the near ventricle with the far ventricle. Thanks, Meenu.
Yeah. So, in our case, we had bilateral myoventriculomegaly on axial. So, TLN, when you have a patient like this, you've seen that both the ventricles are mildly dilated on axial views. What is the first line of investigations that you would want to do?
Basically, it has been very clearly mentioned that ventriculomegaly per se is only a feature, ultrasound feature. It's not a diagnosis.
True.
So when we need to make a diagnosis, there are definitely that we need to extend our examination from the basic views that we normally take as the transthalamic transventricle. Then we need to progress on to do a modified parieto-occipital or the occipitobregmatic views. And the most important thing is, because there is a feature which is suggestive of a mild dilatation of the ventricle, It's also essential to rule out extracranial abnormalities by evaluating the whole of the fetus. That is one aspect of the examination as far as the ventriculomegaly, because you may have certain associated abnormalities which have to be picked up as far as the extracranial situation is concerned. Then, of course, whenever we have one feature which has been picked up on the basic examination, we need to extend our examination and do a detailed neurosonography. Neurosonography, basically, we would like to extend doing evaluation of the fetal brain, both in the sagittal sections, that is two sagittal sections. Basically, what we have with the two sagittal sections are the paramedian as well as the midline sagittal section, mid-sagittal sections. As you can see here, beautifully demonstrated, where it is the paramedian, where you can see what's called as the triventricular appearance. So whole of the lateral ventricle, both of the frontal, occipital, and temporal horns are nicely delineated. You can see the margin of the ventricles beautifully demonstrated in the para. Not only that, you can see the subdural space also clearly delineated. So all these features can be obtained by just doing one para-sag section of the brain. Then the second one is to rule out other possible cranial abnormalities like association with agencies of corpus callosum, abnormalities of the cavum septum pellucidum, as well as you can also make out the abnormalities of the posterior fossa, particularly in the form of Vermean abnormalities, can also be picked up by doing this mid-sag view. And this also will help us in evaluating certain calcarine fissure can be seen very nicely here. So these are the things that we can pick up by doing this sagittal section. Now, this is possible by just doing a transvaginal examination when the fetus is in vertex presentation. But when the fetus is in the breech presentation, it becomes very difficult to get because transvaginal cannot be obtained. In that situation, maybe you will have to depend on the 3D reconstructions of sagittal sections by acquiring a volume. So for example, here we have another thing which we have to keep in mind is taking 4 coronal sections. So basically, when we have a unilateral lateral ventriculomegaly, as Ramamurthy has said, has told us that it has to be done even in the nice coronal transventricular section, we can see both the lateral ventricles, both the frontal horns of the lateral ventricles, if not the whole of the lateral ventricle in the posterior horns. But then the posterior horns can be seen very nicely in the transcerebellar view, where you can see what is called as the owl's eye appearance. This owl's eye appearance is one of the important things that it can also tell us whether there is an asymmetry between the two ventricles. So basically, we extend our examination from the basic examination to the sagittal sections and then the coronal sections. And whenever it is not possible to get a good sagittal and parasagittal as well as coronal sections, we need to recourse on the multiplanar imaging, particularly by acquiring volumes.
Yeah. So, sir, as you suggested, in this case, we did a detailed anatomical evaluation, and we also looked at all the sagittal and the coronal views, which were essentially normal. So now, Ramamurthy sir, at this point of time, considering that the scan is completely normal and the multiplanar neurosonogram done with the transvaginal approach is also normal, would you want to do MRI at this point of time for this patient?
Well, we need to go back a little bit and get to know some information about MRI vis-a-vis ultrasound. Now, you have 2 scenarios which I would like to bring into to your attention. The first scenario is ultrasound done at a basic level, just basic examination axial images versus MRI and a dedicated, fully done neurosonogram, including TVS approach against MRI. So I shouldn't use the word against, versus or compared to MRI. Now, these are 2 different ends of the spectrum. In the first end, where you send a case from a basic examination to MRI, you have a very good chance of picking up something which is abnormal, which ultrasound has missed. Whereas in the second scenario, where you've done a full neurosonogram, including transvaginal, the chance of MRI scoring over or giving us findings, clinically relevant findings, more than what ultrasound shown is very less. Now, if you need figures, I can quote that if you've done a transvaginal neurosonography and then sent it on to MRI, you have precious 1.6% additional findings. That means to say in 98.4%, that means almost 99, let me say 98%, MRI will not add anything more. So therefore, the first question is, first answer is, if you've done a transvaginal ultrasound and if you find nothing, then your chance of finding anything more is very, very less by MRI. So you have an option of not sending this case for MRI. I'll revisit this a little later on. Now, the other thing which is we must really understand is that the person during the MRI is also extremely, extremely important. Just like we as fetal medicine, fetal radiologists or fetal imaging people have to be up and keep up with the latest, the MRI radiologist should be fetus savvy. There's no point in sending it to MRI specialist who is really out of sync with the fetus. That will lead to confusion. So that's extremely, extremely important. Then lastly, of course, I use MRI in a situation like this for one very good reason. Now, here is a mild lateral ventriculomegaly. You have said on ultrasound that it's all normal. You know that you're not going to add anything more, but do you want another modality and another specialist to agree with you and tell you that you have not missed anything, right? Because it's a major thing. This is a very major step to call the lateral ventriculomegaly unisolated. It's one of the very important steps. So from that point of view, I might take recourse to MRI. I might send it out for MRI just to listen to the fact that there's nothing else abnormal, right? And in the process, if I pick up something more, that would be additional. I would look at MRI like that in a scenario, a 26-weeker with a lateral ventriculomegaly and with, of course, no other ultrasound finding, right? So I would discuss this out with the couple and the obstetrician and then take it on from there. If they say, no, okay, doctor, we don't mind, we will go there and get it done. Yes, you can get it done, right?
Yeah, so that's a very valid point. I think MRI, the utility and the amount of information is a lot dependent on the person who's done the scan, ultrasound, versus a person who's going to conduct the fetal MRI for you. So moving on to the next question, that's to Suresh sir. Sir, what are the other tests that you would want to do in this patient?
Once there is a dilated lateral ventricle, then we should think of certain genetic testing, mostly maternal torch infection screening, out of which CMV and toxoplasmosis are the two most important things. Now, we don't screen for platelet alloantibody protein. We don't do that, but we should think of genetic testing in certain specific circumstances and the torch testing with CMV and tox.
Yeah. So Seneesh, talking about genetic testing, if this patient would come to you, what are the genetic tests that you would advise?
Okay, Meenu, now we are in an era where we are slowly moving from the conventional karyotype to microarray. Now, if we see any fetal aberration or any fetal anomaly, we have to think that there are two possible causes behind that. They could be chromosomal or they could be genetic, single gene. Now, this is very much true for ventriculomegaly, where we have chromosomal associations as well as genetic associations. So a practical proposition would be to go for a chromosomal microarray because it picks up much more than a conventional karyotype would. And if you have the resources, and if the pregnancy is in a late mid-second trimester, you could also go for a combination of a rapid aneuploidy testing with a chromosomal microarray. Now, in the chromosomal microarray itself, I would go for something like a mid-resolution one, like a 315K1, so that I balance between the pickup rate and I don't have too many copy number variations of unknown significance. So for this case, I would go for a chromosomal microarray, and I would also ensure that some DNA is stored just in case some new findings are picked up in the third trimester or the baby has some syndromic features after birth. So yeah, so CMA with DNA storage.
Yeah. So thank you, Seneesh. Now, the thing is, life was much easier, I think, 10 years back when karyotype was the only option that was available to us. Just now, we heard Dr. Seneesh telling us about karyotype, about rapid testing, about microarray, and then there were also terminologies used like mid-resolution also. So Dr. Shagun, can you please highlight what is the significance of these tests? How do these actually broadly differ for us clinicians or imaging specialists to know? Because for us, it is always Greek and Latin, and there's always a confusion as to whether I should have done microarray or whether I should have done a whole exome sequencing here. So Dr. Shagun, can you please enlighten us on this aspect of genetic testing?
Thanks, Dr. Meenu. So as Dr. Seneesh pointed out, so we basically have these three types of genetic disorders. So one of them, which everybody is aware of, is of course the chromosomal disorders, Down syndrome, and so many others. So these disorders actually are caused by either a problem in the number of chromosomes or there is a major structural problem. So these, these can be picked up by just doing a simple karyotype because they are visible under the microscope. So, but now, as you said, now life is not so simple. So now we also have so many, other kinds of aberrations or genetic defects which could be there. So one of them is something which we called as a submicroscopic copy number defect or microdeletion, microduplication, one of the common one being the Dijot syndrome. So here basically you have a genetic defect in a very small part of the chromosome, and this is so tiny that the karyotype will not pick it up. So we need a chromosomal microarray, and we can sometimes also use other molecular cytogenetic techniques. And then the third category of condition are the single gene disorder, where the defect is actually at the level of the DNA. So this is even more tinier defect. So this won't come up in a microarray. This won't come up in a karyotype. So for this, we have to actually sequence the DNA. And for doing that, we use various techniques. So if we know a specific diagnosis and that disease is caused by only one gene, which is a small gene, then we can do Sanger sequencing. But again, life is not simple here also, because especially prenatal scenario, you won't reach a specific diagnosis. And even if you do, suppose you make a diagnosis of Meckel-Gruber syndrome, then also there are so many genes which can cause Meckel-Gruber syndrome. So most commonly now what we can use is this new technology called as next generation sequencing. So now, you would ask me that why do we want to do a genetic evaluation in the first place, right? So we all need to realize one thing, that most of the genetic disorders, they would be having intellectual disability in the postnatal period. And many of them have other functional problems or even other structural problems which are not really possible to detect on imaging antenatally, or they may come up later in pregnancy when we are already lost the window of opportunity where the patient can go for a termination. So if you are able to make a genetic diagnosis, at least you can tell these group of patients that the prognosis is likely to be worse. And so they can take a better decision. And also many genetic disorders can recur. So you can give them, you have a specific diagnosis, you can tell how much is the chance of this happening in the next pregnancy. And then you can offer them prevention in next pregnancy by doing early definitive prenatal in first trimester, or even pre-implantation genetic diagnosis if a couple is going for that.
So I think what we all agree to is it's basically rapid aneuploidy screening and chromosomal microarray, which gets offered to everybody when you have a case of isolated ventriculomegaly that gets picked up.
Yes.
But since we also talked about the other tests, what are the common genetic or syndromic aspects of isolated ventriculomegaly that we all should be aware of in brief, Dr. Shagun?
Yeah. So actually for isolated, as we have already discussed, so either doing a karyotype or you could do a rapid aneuploidy to pick up the karyotypic abnormality. Array would give you an additional 6 to 9% yield. So definitely array is the test of choice along with rapid aneuploidy testing. But now to what about the single gene disorders? So right now we know that there are many genetic single gene disorders like the L1 CAM mutations and so many others which also present as ventriculomegaly, but we don't know the exact proportion as of now. So there has been one large study which has showed that at least 3% of prenatally detected CNS malformation, even if isolated, can have a single gene disorder. So it's still very tricky to say whether we should really be going for an NGS in a case like this where you have just a mild isolated ventriculomegaly, unless there is a recurrence in that family or you find something else on scan. So those cases you could consider. Otherwise, just do a DNA banking and we plan it later.
Later on. True. So we did now classify our case as isolated mild ventriculomegaly because the baby was structurally normal. There were no other positive scan findings. Her aneuploidy screen was normal. We also stored the DNA for further testing. Now, Mohit sir, considering she's only 26 weeks, all her tests are normal. When would you ask this patient to come back to you for a follow-up again? And what are the things that you would want to look for in that?
We've already excluded aneuploidy and infection. So ideally, I would like to see her once in 2 weeks. This is specifically to see whether there's any progression. If there's progression, then obviously we are thinking of an obstructive element. If there is no progression, we can probably schedule the interval between scans to 3 to 4 weeks. But what we are interested to see is basically whether we can pick up any additional abnormalities. Now in the transventricular plane, fortunately, you can see the cavum septum, you can see the lateral fissure as well as the ventricles. So you can basically exclude all midline abnormalities, but what we cannot at 20 or 26 weeks is very sure about gyrational abnormalities. So sulcation and gyrational abnormalities is what we should be looking for every time the patient comes for a follow-up. So initially, in 2 weeks, if we don't see the ventricles enlarging, we're still looking for sulcations and gyrations, and then subsequently we can schedule it maybe about 3 to 4 weeks, again looking out for sulcation and gyrations.
Okay, thank you, sir. So Ramamurthy sir, can you please enumerate for us what are the factors on the whole that would affect the prognosis when we are looking at the size of the ventricles and the rest of the things?
Yeah, but before I do this, I'd like to go back to your previous question on MRI. And one important fact that we forgot to highlight is that don't be in a haste to send for MRI.
Yes,
you know, you wait at least for 26 weeks. In your case, that was the perfect time. I say perfect because at 26 weeks, there are some landmarks that one has to demonstrate on ultrasound or MRI. The parieto-occipital fissure and calcareous fissure are grade 3. That means they are narrower but longer, whereas grade 2 is broader but shorter. So I know that it should be quite a long PO sulcus or a calcareous sulcus. The cingulate sulcus should have made its appearance. The acute angle nature of the operculization should have come in, and the convexity sulci should have come in. So now I know if I ask at 26 weeks, I can expect answers as black and white on MRI. Whereas if I ask the same scan at 23 weeks, MRI scan at 23 weeks, now at 23 weeks, none of these landmarks are still there. So therefore, I don't know, I might have to refer her again. So therefore, the idea is to get maximum out of one scan and please place it at around 26 weeks because you expect certain events, landmark findings to have made their appearance already. Now coming to this, the current question, what are the factors which affect prognosis? So now we've really come down to the level where we've done a good ultrasound, MRI, nothing intracranial, nothing more extracranial. Number 2, the infection profile is negative. And number 3, the chromosomal microarray is normal and we've got the DNA banked for future use. Now, this is truly what is known as an isolated mild lateral ventriculomegaly. And now what we're going to discuss is going to apply to an isolated. In the process of getting through the process of trying to identify any associated, if we find an associated finding, the prognosis is on the basis of the new finding. For example, you've done a chromosomal microarray, you pick up a Down syndrome, your counseling will be for Down syndrome. If you pick up another kind of a situation, an infection kind of a situation, your counseling is going to vary and it's going to get into that realm. So therefore, in an isolated lateral ventriculomegaly, size is important. First of all, if it's mild, that's 10 to 11.9 millimeters, your prognosis is that in 93% this individual fetus, in its pediatric adult age, when it gets into the adult age group, 93% normal, 7% neurodevelopmental delay. If the size of the ventricle is 12 to 14.9 millimeters, that's just short of 15. So 12 to 15, if you say, then your the normal rate, the rate of neurodevelopmental delay goes up to 11%. So you're really choosing to counsel from 7% to 11%. The bottom of the story is not the 7 and 11. The bottom of the story is that you're unable to answer this couple one vital question. Doctor, we will do everything that you are going to tell us to do, but let us know if everything comes abnormal, will our child be normal? Sadly, at this point of time, the answer is no. We still have to tell them that, yes, about 90% of times normal, about 7 to 10% of times there will be a possibility of neurodevelopmental delay. So size is important. Of course, the association with additional abnormalities is extremely important. And of course, whether this ventriculomegaly progresses or not is extremely, extremely important, because if the ventriculomegaly progresses, as was discussed by Dr. Mohit, the chance of neurodevelopmental delay goes up to almost 16%. Unilateral, bilateral really doesn't matter, but if it's unilateral, I would think of clastic lesions on the same side. I would think of a hemimegalencephaly. I would think of a hemiatrophy. I would think of a tuberous sclerosis with a tuber sitting at the foramen of Monroe causing a unilateral. So, you know, when it's unilateral, your shift goes to, you're forced to think of a certain list of conditions, but mind you, a unilateral lateral ventriculomegaly needs the same kind of approach as a bilateral lateral ventriculomegaly. And symmetry versus asymmetry. Actually, if you see, asymmetric ventriculomegaly is more common than symmetric ventriculomegaly. But if you look at associated abnormalities, symmetric has more of associated intracranial, asymmetric has little lesser. Again, not statistically important. We've got to do what we have to do as in any other case of a mild lateral ventriculomegaly. The same protocol holds. Yes, Dr. Meenu.
Yeah. So I think the $1 million question still remains with the patient. The patient still wants to know, is my baby normal? And wherein comes the most important part of the counseling, where you have to tell her about what is the neurological outcome. So, sir, if this patient has come to you now, how would you, Suresh sir, how would you counsel the patient regarding, you know, the neurological outcome? This is a case of isolated mild ventriculomegaly, which is a diagnosis of exclusion, as we know. But how would you counsel this patient?
I think a lot of it, as Ramamurthy has mentioned. First of all, we need to identify the cause. The counseling will depend on the cause. So if you have done all your investigations and there's a clear direction of a genetic cause or a karyotypic cause, then the counseling goes in that direction. Second is it truly isolated? And what do you mean by isolated? As we have ruled out all other abnormalities, and also with your routine testing, you ruled out infection, then it's truly isolated. Third is it progressive? Here is where the problem comes. You are seeing the patient at a particular point in time, let's say 20 weeks. Now, to answer a question, is it progressive? We need to call the patient back after 2 weeks or so to see whether it has progressed or not. But at the time at which you are diagnosing it, then to know whether it's progressive or no is not going to be. That's the uncertainty which is going to be there. So we know that karyotypic abnormality is present at about 5%, but that is more if there are associated abnormalities, as compared to when there are no other associated abnormalities, where the karyotypic abnormality is only 3%. Now the second thing is, we were talking about mild versus severe ventriculomegaly as 15 mm as the cutoff. Now this paper actually divided into a subgroup between 10 and 12 millimeters, if you call it as mild, then most of them have a favorable outcome. Whereas when you between 13 and 15 millimeters, which is moderate, most of them, there's a likely favorable outcome, but there's a higher incidence of neurodevelopmental disability. And this is at about 3 years and 6 months. So the question is, these babies also will do well, but the learning disabilities, for example, will be lesser, will be higher when there's between 13 and 15 millimeters.
So in our case, actually, that patient is now 34 weeks. It is an ongoing pregnancy. And she had a scan last week where both the ventricles are measuring 9 millimeters. We have not been able to find anything else. So we are treating it as isolated fetal ventriculomegaly, and she's carrying on with her pregnancy. Coming to the next case, this was a second gravida who was referred to us for small cerebellum and unilateral prominent lateral ventricles. This was a second pregnancy and the combined test was negative. Praveen sir, can you please describe the ultrasound findings that have been shown in these clips?
Right. There are two clips. One is the transverse section of the fetal spine. The other one is the sagittal section of the fetal spine. Let us take first the transverse section. The transverse section, basically, if you look at it, we can see that it is almost at the lumbosacral region, because you can see the fetal kidneys as well as mild pelvis being mildly dilated. And you can also see the distal part of the sacrum. So it is the lumbosacral region where you have. Now, when we look into the transverse section, the basic important thing is to see whether there is any splaying of the lamina. As there is splaying of the lamina, and you can see them very clearly, and you can have a cup-shaped appearance with a membrane which is seen above it with thin septations. Not only that, we can see that there is a discontinuity in the or aberration of the skin. And if you go back to the sagittal section, in the sagittal section, we can very clearly delineate that there is a cystic area at the distal end of the lumbosacral region. Along with it, we can find that there is tethering of the card. You can see the card right going up to that area with very little fluid and along the dorsal aspect of the card. And that is one of the most important factors which we have to consider, because when we are dealing with the prognostication of these fetuses, this is one of the most important factors that we have to keep in mind. So basically what we have is that whenever we see these cases, particularly the spinal, open spinal defect, it is incomplete if you don't evaluate the cranium. The cranial features are extremely important, not only that because there is associated Ornard-Chari 2 malformation, where you have ventriculomegaly, you have what is called as the lemon sign, as well as the banana sign, all these things which have been defined by Kipros way back, which are the indirect evidences of or indirect signs of open spinal neural tube defects. So in this one, again, we have a classical appearance of the fetal head, which is having the lemon shine. And at the same time, when you can see in this one, you can see the ventriculomegaly. And at the same time, when you see this particular one, I think the cerebellar hemispheres, I mean, there is almost like a banana-shaped cerebellar hemispheres, which are very classically seen. So these are the features which are extremely important in order to identify or pinpoint your diagnosis that it is the sacral open neural tube defect that we are dealing with.
So we often miss the diagnosis. So but Ramamurthy sir, to avoid that, can you highlight for all of us what is the standard imaging protocol that we need to follow when we are assessing the spine during a mid-trimester anomaly scan?
Well, the spine has to be assessed in all 3 planes, no shortcuts. No saying, I won't see the coronal planes, I'll just do the sagittal and transverse and I'm fine. No, that's not it. We need to study in all 3 planes. Now, sagittal section is a must because it shows us almost a good length of the spine in each of the pictures that we take. Each of the pictures that we take, a good length of the spine is seen. We see 2 rows, a posterior row of ossific centers and an anterior row of ossific centers. Remember, the skin over the spine should be observed. It's not only those echogenic spots and the way they are arranged. The skin should be studied. And to study the skin, it's always better to have a layer of amniotic fluid separating the dorsum of the fetus from the uterine wall. Needless to say, we need to wait for dorso-anterior or a dorso-anterolateral so that you can get your spine anterior position by using your probe skill, maneuvering skill. Again, in the sagittal view, I would not only be interested in looking at the general 2 railroad kind of appearance of the centers, but I'll put my special effort into the sacral end because the sacrum should be complete, number 1. There should be a good taper. the sacrum is up tilted, and again the skin on the sacrum should be seen. So that is the way I would do a sagittal section. And in terms of doing the sagittal section, I will always try to use, if there is an abnormality, I will always try to use a high frequency probe, or I would try, if it's vaginally accessible, I would do a vaginal scan to see that part of the spine, lumbosacral spine, closer to the internal os, from the conus medullaris and the phylum terminal point of view. I think we'll come to that a little later. But moving from the sagittal section, we go on to the transverse section. The three dots should be seen as an equilateral triangle, and this equilateral triangle should be checked out from C1 down to S4, C1 down to S4, in terms of a couple of sweeps that we can take. If you're finicky on documentation, please record this clip. That would stand us in good stead. And all over again, or at all levels, we need to look at skin continuity over the spine. And again, like her, between the uterine wall and the dorsum will definitely help. Lastly, coronal section the use of coronal section cannot be underestimated. You can go a little anterior, you get the anterior ossific centers as a single line, as you can see on the picture on top. Or if you go a little posterior, you get the classical railroad appearance, two parallel rows of the posterior ossific centers. Again, these two converge in the sacrum as a sacral taper. Now here, what is important is to look for alignment. Is the spine, the centers arranged in one straight line, or is there a local kink or multiple kinks which are present? That is important, and that means you're dealing with a hemivertebra. It could be a single hemivertebra, it could be multiple hemivertebrae, but if we do not do a coronal section, we cannot diagnose a hemivertebra. It's very important to realize that hemivertebra cannot be seen in sagittal and axial sections. You might kind of, there's something wrong, but you can't demonstrate it. It only hits your eye if you do a coronal section. So these are the three methods. Use clips, use stills to document the spine, and you might need more than one section because of the kyphosis. You might need more than one section to demonstrate the coronals in the entire length of the spine. Yes, Dr. Meenu.
Yeah, and so what about the assessment of the conus?
The conus, as I said, I briefly alluded to this. You need to magnify, you need to go as high a frequency as possible on your transducer, do a pure mid-sagittal section, and in a very pure mid-sagittal section, you actually don't see two rows. It's only a little parasagittal, you see two rows, one anterior, one posterior. But when you go bang middle, you go actually in between the two posterior, and you expose the dural tube to beautiful display. And when you do that, you see the cord as a hypoechoic structure, and the hypoechoic structure tapers to form what is known as conus medullaris. The tip of the conus medullaris in the second trimester is between the lower border of L2 and the lower border of L3. Any conus in the second trimester going past L3 lower border is called a tethered cord, is called a low conus, right? That's number one. Number two, the spinal cord actually is hugging on the anterior, that is the ventral aspect of the canal. It's never seen on the dorsal aspect. So make sure that you see this spinal cord going all the way on the ventral aspect. If there's a spina bifida, and if the spine, the roots are going out, the spinal cord gets hitched up and it leaves the ventral aspect, goes to the dorsal aspect. Right? So therefore, conus medullaris can be very, very well demonstrated. Higher frequency, position, magnification, extremely important. And as I said, if it comes to that, you might even use a transvaginal approach, provided the sacrum is close to the internal os. Yes, Dr. Meenu.
Thank you, sir. So, Mohit sir, what are the specific situations or scenarios where you would want to use a high resolution linear probe? Because I was saying that we can use it to evaluate the spine. When would you want to do that?
High resolution by definition means it will give you superior resolution for near field, whereas it compromises on penetration. So obviously the spine has to be in an anterior position. We should take care that, there is some amount of amniotic fluid between the spine. The spine is not abutting the uterine wall. And more importantly, if you need to look at the spinal cord, we need to go in the bang in the midline. As Dr. Ramamurthy sir said, the posterior ossific nuclei are paramedian. So in between, if you go through the take a bang mid-sag section, you will be directly interrogating the spinal cord, which will be seen as a tubular hypoechoic cord-like structure in the central portion of the spinal canal, and you will see in the vertebral canal, and you will see that you can actually see it till it ends in the conus medullaris. So it's almost of a uniform diameter, except at the conus medullaris where it may be slightly widened. You can actually, even on a high frequency, see the central canal, the central spinal canal, as an echogenic line. So you would use the high frequency probe to see the spinal cord better. And in fact, when you document an image, it is wise that you go from the conus medullaris up to the sacral tip, so that if you want to calculate the vertebral bodies, it becomes easier when you have documented the lower portion of the conus along with the sacral tip. Also, it allows you to visualize normal variants in like a filar cyst or even a ventriculus terminalis, which otherwise would have been difficult with a low frequency convex transducer. But the real use comes when we deal with pathologies like meningomyelocele, tethered cords, where you see that the cord is low lying below L3 and tethered dorsally within the vertebral canal. And also you can see a fat component within the vertebral canal to see in cases of intraspinal lipomas. And these are the clear indications where high frequency will yield a more accurate diagnosis, Dr. Meenu.
Yeah. So Seneesh,
Sorry to interrupt.
yeah.
Meenu,
Yes.
there is Dr. Suresh wanted to ask something from Ramamurthy, Dr. Ramamurthy.
Yes.
Ramamurthy or Mohit, just you said conus ends at the level of L2. So how do you identify L2?
That's the question that
yeah, we can
Okay.
actually.
Yeah, that's the question which is going to Dr. Seneesh now, Dr. Suresh. How do you count?
Okay, Meenu, you have the soft tissue landmarks and you have bony landmarks to count the level of lesion. Now, first of all, when we use the word level of lesion, we mean the first vertebra, which is open, to differentiate from the neurological level, which is different from this. Now, the first vertebra, which is open, defines the upper level, and you have soft tissue landmarks and you have bony landmarks. Now, for open spina bifida, of course, the bony landmarks are easier than looking at, say, for example, the upper pole of kidney. So what most of us do is count the vertebra from a craniocaudal direction. Now, the T last rib, it corresponds to the 12th vertebra, and from there you can count downwards. Now, how to count? You require the fetus to be in the prone position, and there needs to be sufficient light above it, and you can acquire a 3D volume of the fetus and get the coronal plane, and then from there you can in the maximum mode or skeletal mode, and from there you can count from the craniocaudal direction, starting from the T12 vertebra, which corresponds to the last rib.
Okay. Or yeah, we can roughly, if you look at the kidneys also, I think it corresponds to around L1, L2 level, which tells you that, it is at the conus would also be at the right levels if you're not able to count all the times. Yeah, so we found that the upper level of lesion in our case was L3. The patient was already 24 weeks. So obviously she now wanted to know what are the prognostic factors. So Suresh, can you please highlight on how would you prognosticate this? What would the prognosticating factors that you would want to look at in this pregnancy?
So the prognostication actually depends on the type of defect. It is open neural tube defect or a closed neural tube defect. Abnormal KT in about 16%, especially when associated with other anomalies. It also depends on the level of the lesion. And as we said earlier, whether there is progressive ventriculomegaly. The main factors we are concerned with is whether this ventriculomegaly will increase and then shunting will be required, ability to walk independently, or they will be wheelchair dependent or walking with support, developmental delay, neuropathic bladder, and bowel dysfunction. Of these, you will find that neuropathic bladder is found in a large number of patients, and that, of course, everything depends on the level at which the lesion is. And similarly, the ability to walk independently in ONTD is only 45%, whereas in closed NTD is almost 100%. And the walking with support, but more or less similar. Bowel dysfunction is more again in ONTD as compared to that. So when we talk to the patients, when we talk about these are the factors that are possible that could happen, and it would depend on the level of the lesion and also the length of the lesion which is there and the associated anomalies which are there.
So, sir, Praveen sir, can you briefly tell us what is the outcome that is expected usually based on the spinal segment involvement?
See, basically there are two components. One, anyway, Dr. Suresh has already told us the level of involvement. Not only the level of involvement, the larger the segment, the poorer the clinical sequelae are. That is, the severe clinical sequelae will be. Now, basically, you can categorize them as follows. In the sense, in case if the lesion is limited to thoracic to L2 level, 50% of them are associated with dysphasias. Whereas if it is between L3 to S1, there is a possibility of bladder dysfunction as well as sexual disorders also. And if it is associated, I mean, the associated limb abnormalities also we have to look for. The limb abnormalities depend on various segments, which I think we will get into this in further questions.
Yeah. So, Ramurthy sir, we are only talking about on scan till now about the anatomical level of the lesion. So, do you think that is sufficient enough to actually prognosticate and tell her, you know, this is what the fetus, the baby is going to face postnatally?
Well, at the moment, that's what most of us are doing, but we should always realize that there is not only the anatomical level, which is also in literature, if you read literature, the anatomical level is referred to as the radiological level, because after the baby is born, it's the X-ray or the MRI which tells you the level of the lesion as well. So it's not only the radiological or anatomical level, it is also the functional level. Remember, the cord is tethered. When it's tethered, the whole cord has moved down. And when it moves down, at L2, you don't find the L2 level cord. You will find somewhere around L1 or T12, isn't it? Because the cord is pulled down. So therefore, you have what is known as the neurological level. The neurological level is about 1 or 2 segments higher than the anatomical level, right? But there are people who have groups who are studied. You're flashing Carreras over here, and that gives me a deja vu phenomenon, deja vu feeling. These people have sat and looked at every fetus for 45 minutes. Yeah. And if the fetus flexes the hip, L1 is good. If the fetus extends the knee, L3 is good. If the hip is adducted, L2 is good. If the knee flexes, L4. Dorsiflexion of the ankle, if that is seen on ultrasound, L5 is good. And S1 is if there's a plantar flexion, right? I think this is a protocol which is heavily time dependent. And at the moment, I do not know what is the acceptability in our fraternity going to be. But needless to say, the level can change between the anatomical level and the functional level. And most of this is done postnatally at the moment.
So the important thing we have to understand here is that even though we are categorizing the anatomical level, the prognosis might be worse because the functional level can be much higher. Because
absolutely. Absolutely.
So, Sir Suresh sir, apart from the motor level, what are the other consequences that we need to inform while we are counseling the patients? Motor level is one aspect. Suresh sir?
One is ventriculomegaly that may be present and that may also increase, and cognitive development. IQ is very important, and they are higher when there is more ventriculomegaly. The IQ is lower, and certainly motor function which we see antenatally. We say limbs are moving, and when we report on that, it doesn't mean the limbs will move later on. So that's what a temporary function which we see antenatally. That's completely different what's going to happen postnatally. And also, when there is a lower lumbar sacral, as Ramurthy has said, then some independent ambulation is certainly possible. And as the lesion goes higher, then we have problem. The biggest problem is bladder dysfunction. And bladder dysfunction, as I said, is present in majority of the people, and they may have to self-catheterization, and with they have be trained in such things, and they will be put on drugs. Infections are the main issue which needs to be controlled about, especially because of repeated self-catheterization. And training is very, very important. So you need actually a support group which helps these children along for a long-term solution. And of course, reproductive function is also something we need to consider. And as we know that depending on the level, there's decreased sexual activity with spinal dystrophy.
So, Dr. Shagun, in a case of isolated open neural tube defect, do you think we should be doing genetic testing for this fetus?
Even though this is looking like an isolated spina bifida over here, and we know that actually majority are multifactorial, that is, it's a interplay of genes and environment, but still 1 to 10% cases can have an abnormality on karyotype, and this would obviously change your prognosis because these children would fare much worse. And but here usually microarray or NGS, these tests are not really required because the yield of these are likely to be extremely low. So but definitely at least we should be doing a karyotype, and if the patient is affording, an array can also be offered. Again, DNA banking becomes important, and many of these patients would go for termination of pregnancy. So again, very important here is to do an autopsy to see any syndromic features. And then accordingly, depending on the findings, we can provide them recurrence risk for next pregnancies.
So, in recurrent cases, should we be doing this MTHFR gene testing? What is your opinion on that?
So actually, MTHFR, and even there are certain other genes also of folate metabolism. So some mutations, or basically we call them as polymorphism, they increase the risk of recurrent NTDs. So around 1.3 to 1.4 times. But this usually, this would not really have any implications for managing your patient, because once a patient has a neural tube defect, you would automatically be giving her the high dose folate for prevention the next time. So doing this testing doesn't add anything in managing the patient, in fact. So we don't really recommend testing for MTHFR in cases of recurrent NTD.
So Seneesh, what would you recommend basically for prevention of open neural tube defects? And I also want to ask, is there something, what are the signs that you would have looked for in the first trimester to screen this fetus for open neural tube defects?
Okay, Meenu, the standard teaching from our undergraduate days has been for the high-risk woman, that is a woman who had a pregnancy with a fetus or a baby with open spina bifida, is to give 4 milligram per day of folic acid. Now, this figure has actually come from the British Medical Council research multi-center trial in 1991. And after that, this dose has not changed at all. For a woman who is not at high risk, the standard recommendation dose is 400 microgram, and starting from the conception. Now we need to know few things about this. It is not as simple as we think. Now, if you see the cohort of pregnant woman or the high risk woman who had a baby with open spina bifida, there are actually two groups within them. There is a group which is folate sensitive, and there is a group which is folate resistant. So the dose which we recommend of 4 milligram per day is actually for the folate sensitive woman, which is actually 2/3 of the cohort. Now, there is a 1/3 of this cohort will be folate insensitive, and therefore we have to do a targeted early trimester scan and routine mid-trimester morphology scan to pick the neural tube defects in them. And coming on to the first trimester signs that has already been beautifully depicted by Praveen sir in his quiz. But let us have a different perspective now. Now, the signs can be divided into objective signs and subjective signs. The objective signs include the measurement of biparietal diameter. If it falls below 5th, It's seen in 60% cases of open spina bifida. You could also measure the intracranial translucency. You can measure the BS OB distance. And you can also have a look at the maxillary occipital line, which has been a new sign. The subjective signs, have a look at in your normal mid-sagittal plane that you take for your NT. Look at the intracranial translucency. Look at the BS-OB distance. And most importantly, go into the axial section of the fetus or the fetal head and look at the caudal displacement of the brainstem and non-visualization of cisterna magna. Now, for a practical approach, a combination of looking at the intracranial translucency, the BS-OB distance, with the axial signs of caudal displacement of the brainstem, cisterna magna, and the head and the biparietal diameter less than 5th centile would enable you to pick up almost all cases of open spina bifida in the first trimester.
Okay, we have a lot of questions popping up and there is shortage of time. So we have 10 minutes more, but I think we'll take this one case quickly where the patient was again referred for a second opinion for ventriculomegaly and Vermean hypoplasia. So Mohit sir, can you please describe what we see in this axial imaging of the brain?
Yeah, this is the transcerebellar plane. So the posterior fossa is best visualized in this plane, where you normally see two hypoechoic cerebellar hemispheres and a relatively echogenic bridging vermis, giving the typical dumbbell appearance. And if you slightly give a further caudal angulation, you should see the fourth ventricle. And the vermis should be separating the fourth ventricle from the cisterna magna in normal circumstances. What we see here is the cisterna magna is communicating with the fourth ventricle, and this entity is called the fourth ventricle. Now, if you realize that it's a craniocaudal axial view, if you see a communicating on an open fourth ventricle, it means either that the inferior portion of the vermis is not present, it's absent, or the vermis is upwards rotated, either of the two. So you need further sagittal sections to further evaluate this abnormality.
Yeah. So before we go for further evaluation, Praveen, so can we see this normally as well? Or is it always that there will be an abnormality?
No, it all depends on when you are scanning the patient. If suppose you are scanning her very early, let us say about 18 weeks or 19 weeks, and you still can expect that there can be some amount of communication between the fourth and the cisterna magna, fourth ventricle and the cisterna magna. Another important aspect which we all have to keep in mind very clearly is the technical aspect. That is, if you are tilting your transducer in a transcerebellar view more caudally, in that situation, what happens is you will miss the vermis, and it appears as if you have an absent vermis or a hypoplastic vermis. So the technical aspect and the age at which you are scanning, the gestation age at which you are scanning the fetus is what is important as far as the communication of the fourth ventricle with the cisterna magna. So that's how you decide the normalcy of it.
Yeah,
so now, as you have shown these images very nicely, at different ages, we know that the fourth ventricle is definitely communicating with it. And at the same time, depending on the angulation, you can see once you angulate it properly, you can see the vermis as a rectangular echogenic area and fourth ventricle in front of it as a rectangular. Right.
Yeah. Next. So Seneesh, now you have more than 20 weeks gestation fetus with an open fourth ventricle. What are your differentials and what would be your next step?
The differentials are very easy, Meenu. You have to differentiate between three conditions: Blake-Spout cyst, and more ominous differentials such as Dandy-Walker malformation and Vermean hypoplasia. Now, once you see an open fourth ventricle in your standard axial plane, the next step is you have to go for an advanced neurosonogram, and that would include insonation of the fetal head with a high-resolution probe, going for a transvaginal ultrasound, and wherever possible, the 3D ultrasound to obtain all the three images of, all the three planes of the fetal brain to obtain additional signs and diagnostic clues.
Yeah. So Ramamurthy sir, can you please describe what are the important planes and points in the evaluation of the posterior fossa?
Well, again, the posterior fossa should be imaged in all the three planes if you're doing a total neurosonogram. But in the basic plane, the posterior fossa is evaluated in the occipitobrygmatic plane or the transcerebellar plane. And even in this one plane, seemingly one plane, we should realize that there is a little cephaloid cut which takes you through what is seen in the picture now. You see the two hypoechoic cerebellar hemispheres, and you see a relatively hyperechoic vermis sandwiched between the two. So the dumbbell-shaped cerebellum is classically seen in this particular view, and behind, or the space of CSF seen behind the cerebellum, is the cisterna magna, and behind that is the occipital bone, and then the nuchal fold thickness if you're within the window of the second trimester genetic sonogram. Now, this is the anatomy that we see in a slightly cephalad plane. If I move a little more caudad, then what I see is the fourth ventricle, the vermis, and the cisterna magna. So the fourth ventricle on axial section is always wider than longer. That means its transverse diameter is more, the AP diameter is less. And this is a very simple sign, and we need to do and document this plane as well when we do the occipitobrygmatic plane. Because if this side-to-side length is replaced by AP length being more, then that is associated with posterior fossa abnormalities, and that becomes a kind of a screening feature for the posterior fossa in particular. So that's as far as the axial goes. The vermis in the mid-sagittal section actually is a very, very eye-catching structure. Because of the number of foci that it has, fissures that it has, there's a lot of pia matter going into the neurological substance of the vermis. And once pia is in profusion, you find that the echogenicity is more, and that is exactly why you see the vermis as glowing like a light bulb. It's hyperechoic, as it was in the axial plane. Now, it's a classical kidney bean appearance. The hilum of the kidney bean is actually the highest point of the fourth ventricle, and we call this the fastigium. The upper portion of the kidney bean is a little narrower than the lower portion. The upper portion, the 1/3 versus the lower 2/3 is marked by the primary fissure, which you see as a small little indentation if you zoom this image. So the presence of the kidney bean shape, the presence of the fastigium, the presence of the primary fissure, and this 1/3, 2/3 arrangement all tells me that the vermis is normal in size and shape. You can objectify the size by doing a cephalocaudal diameter as well as an anteroposterior diameter. Now, the other aspect of the vermis which we must consider is its position. The upper pole of the vermis is relatively fixed. And in the lesions which Seneesh described, the cystic midline lesions, there is what is known as a rotation of the vermis. Rotation of the vermis is nothing but lifting off of the lower pole. Remember, the upper pole is fixed. You've got the medullary velum or veli. There are three of them, three peduncles, which are there. They are fixed. The lower pole is lifted off. So when it lifts off, it becomes, it kind of makes an angle with the brainstem. So showing that there is no rotation, showing that the morphology is normal, the size is normal, is the essence of calling a vermis as normal. Lastly, the coronal section will show you the same as what you see on an axial section. You see the intermediate sandwiched echogenic with the dumbbell, the weight of the dumbbell on either side being the hemispheres. I think the three planes are important, but we do the second and the third plane only if we have a problem in the plane one. And one of the problems that you've already started discussing is the open fourth ventricle. Yes, Dr. Meenu.
Yeah, so Praveen sir, I think vermis is the most important structure that needs to be assessed here. So sir, quickly, can you just tell us what are the important things that we need to look at so that we would be able to differentiate between these three differentials that Seneesh had mentioned, because the prognosis is completely different in three scenarios?
Yeah, there are majorly three factors that we are going to consider. One is the biometry, second is the morphology, third is the location. If you take the biometry, you need to assess the size of the vermis. And the size of the vermis, as Ramamurthy has said, there are various ways. That is, you take the caudocranial as well as the AP. But the present thinking is that it is always essential to take the area of the vermis rather than the AP or the craniocaudal measurements. Because once you have the area, you can have a ratio between the BPD, and then you can assess the smallness of the vermis. The second important factor is the morphology. Morphology, as we know, we have been very clearly delineated. There are basically three lobes. Most of the important thing is that this indentation, which you can see because of the primary fissure, is one thing which is extremely important. And not only that, the most important thing is whenever there is a Vermean abnormality, as far as the morphology is concerned, not only the size, but also the absence of normal looking vermis, that is the kidney shaped vermis, will also be lost, and the fastigium will not be clearly delineated. The third one is the rotation. As it is anchored above, it is displaced upwards. As it gets displaced upwards, there is always a rotation which can be assessed by taking what is called as the BV angle or the BT angle. So both these BT angle and BV angle are taken into consideration to assess the location of the vermis. But then the problem is that there is a lot of overlap between in the BV angle. Because of the overlap in the BV angle, it is difficult to differentiate particularly between the brachial, the Blake's pouch cyst and the Vermean hypoplasia. Whereas in the Dandy-Walker malformation, definitely there will be a much more increase. So in order to minimize this overlap, we take into consideration size, taking into consideration the ratio between the Vermean area versus the biparietal diameter. If it is less than, it is more than 1.1, it is Blake's pouch cyst. If it is less than 1.1, we consider it as Vermean hypoplasia. Not only that, the another important thing is the location of the choroid plexus of the fourth ventricle. If the choroid plexus of the fourth ventricle, which I have shown you in the quiz, where if it is located infero-laterally, we know that we are dealing with a Vermean hypoplasia. If it is located superior-laterally, then we know that it is dealing with a Blake's pouch cyst. Basically, the problem is between the Blake's pouch and the Vermean hypoplasia, it becomes very difficult to differentiate one from the other, because in Blake's pouch also there is mild rotation. Vermean hypoplasia, there is rotation. Only one most important thing is that the morphology is altered, the size is altered, the tentorium is normal. So differentiating between the Vermean hypoplasia and the Dandy-Walker, we have the elevation of the tentorium, which is going to be of help. So this is how you are going to evaluate the vermis in total.
So Seneesh, how does 3D help? I mean, is it mandatory that for all cases you should do a transvaginal with a 3D ultrasound as well?
Meenu, the fetal CNS is one system where the clues, the clues or the signs lie in the normal standard plane, and the diagnostic evidence lies in the orthogonal plane. And for that matter, three-dimensional ultrasound is often a necessity than a leisure. So yes, whenever you see some primary lesion from the primary planes, then you have to go and image the orthogonal planes. So that would require the use of three-dimensional ultrasound. In the simplest form, you can do a multiplanar imaging where your A plane is usually the transcerebellar plane, and you can look at the vermis and the corpus callosum in the C plane. Or you can go for a tomographic ultrasound imaging, which shows the depth of your lesion. You can use the algorithms of volume contrast image to enhance the soft tissue distribution and study the morphology of the vermis, the corpus callosum, the ventricle, the cerebral cortex very nicely. And of course, you can go for other modes, such as you can go for a render mode, and you can use 3D for 3D color Doppler as well to study the vascular lesions. So yes, 3D is most commonly required for evaluation of the fetal CNS lesions.
Yeah. So we did a detailed transvaginal neurosonography on which we saw that the BV angle was only around 9 degrees. There was a Blake's pouch cyst, which was also appreciated in the coronal videos. And we asked her to come for a follow-up after 2 weeks. This was the second visit. Again, it was consistent with Blake's pouch cyst. The third visit. And finally, she came to us at 30 weeks, after which the patient was actually lost to follow-up. We recently called her and found that she had the MRI for her baby, which it was a female baby that was born, which showed that everything was normal except that the cisterna magna was slightly prominent. So I think the important thing here is to follow a standardized protocol and not jump onto conclusions only when you just see a communication between the fourth ventricle and the cisterna magna on axial planes. A detailed stepwise multiplanar imaging is very, very important. So Dr. Shagun, do you think we should be doing genetic testing here? Because that is, again, always that genetics part is what is confusing. isolated Blake spout cyst, should we be doing karyotyping for this patient or any kind of genetic invasive testing for that matter?
So actually, we would recommend doing a karyotype at least, because there are reports and there is a recent meta-analysis also which says that up to 5% of cases with isolated Blake spout cyst can have karyotypic abnormalities. So at least a karyotype should be done. Other tests, as of now, we don't have any evidence. But as like we have seen now also, like we all realize that there are diagnostic challenges with respect to vermis hypoplasia and other posterior fossa lesions. So this is very important. I mean, the imaging is really important because these other lesions will have a very, very high risk of being associated with genetic syndromes, and they will recur also. So that distinguishing from other lesions is very important, and hence that postnatal follow-up is also extremely important for these cases. So here in this case, I mean, as I saw, so there doesn't seem to be anything else besides prominence cystana magna. So this luckily seems to be a favorable outcome. But
So,
it's important to do a karyotype and important to keep a follow-up and make sure that we are not losing out the other lesions or any associated anomalies.
so Suresh sir, can you tell us, like, when you see the spectrum of posterior fossa anomalies, how would you counsel these patients?
I think we've got the answers that Blake spout cyst is usually something which is, when it is isolated, it has a very, very good outcome. So you do a basic karyotype and the karyotype is normal. In fact, what they say about association with chromosomal abnormalities is usually trisomy 21. And that 5% association is usually when you see other markers. When there are no other markers of T21, then the outcome is supposed to be very, very favorable. And neurologically also they do well. But when you talk of inferior Wormian hypoplasia, then they have fairly more than 75% of them have a fairly good outcome. But when you took of cerebellar Wormian hypoplasia as such, now they are associated, the prognosis can be very, very varied. It could be part of a Mendelian syndrome. So prognosis is often worse when it's associated with a Mendelian syndrome, worse than a classical DWF. Also, we should say that they would have potentially intellectual disability, seizures, and spasticity. All this may be associated when there is a classical DWM and also Wormian hypoplasia. And of course, postnatally, whatever we do antenatally, if we are going to prognosticate for the child further, a postnatal MRI is very important because we need to get a very clear picture of what is happening and decide on whether genetic testing is required or not required, especially when the anomaly is diagnosed late. You may not have time to do it antenatally, you wait till postnatal, and after the baby is born, then prognostication comes with all the data in front to see how they will progress forward.
Yeah, that's a very valid point, sir. We would not be taking the last case because of shortage of time.
Yeah.
And what I think the main message that we all need to take here is, when we talk about prognostication, it is very important that we all follow standard protocols of imaging. We need to have standardized protocols on how we are going to follow up these fetuses when we have a prenatal diagnosis. And the biggest dilemma here is counseling them about long-term outcomes, because there is so much variability in the way different studies have been done. I think it is very important that we have much more larger studies so that we can understand what are the long-term disabilities versus what are the early affections that the fetus can have as far as impact on their quality of life is concerned. Thank you very much, everybody, and have a happy day.